You know, basically you guys kind of are in the trenches, you know, with all these neuro patients that we see. So what we thought we'd do is just kind of walk you through, you know, sort of from our perspective, kind of give you a little overview of what Erlanger, you know, the stroke center has, you know, how it's been developed over the years and the type of patients that we treat from an interventional point of view. And as Gail said, you know, obviously this is very informal, interactive, and so, you know, just feel free anytime to ask questions or whatever. Okay, so yeah, you know, here we are, obviously Chattanooga, and one thing that a lot of people don't know about, you know, the area that we live in is that it's really deep in the heart of the stroke belt. So all this, you know, the southern states have kind of earned this designation as being the stroke belt. And often, you know, we jokingly say that Chattanooga is kind of the buckle of the belt because we do have a very high incidence of stroke. If you look at the numbers, we're about 300% the national average for stroke. So, and then, you know, again, in our county here, Hamilton County, you know, about 10,000 strokes per year, 4,000 deaths, which is a lot from a national perspective. And that's what makes us one of the busiest stroke centers. And then when you give talks, I mean, everyone is trying to figure out, well, why are we having all these strokes? And I jokingly kind of put in these slides. So we do have a few dietary issues that may contribute to that. It's not all diet, though. It's you know, there's other factors. We live in a warm climate. A lot of the young patients that we do see, often in their, you know, investigations, we uncover that they have some kind of abnormal clotting disorder. You know, so it's a genetic predisposition. So it's kind of a perfect storm, if you like, for, you know, the symptoms and stuff of having strokes. And unfortunately, one of the things that really struck me, so I came 14 years ago. My accent is a little crazy. It's not for, you know, locals, Canadian, who say the oats and the boats. But you know, when I came here, something that really struck me about the stroke work was not only that we had a huge number of patients having strokes, but it was really that there were a lot of young patients. The first 3 patients that I got called in for, you know, and this was in the day when we were, from an intervention point of view, we were kind of, you know, putting a microcatheter in the clot, dripping in a little Drano equivalent, you know, a clot busting drug, the TPA, and the oldest of these patients was 33, and the other 2 were in their 20s. So unfortunately, you know, at this center, this type of a patient who is 26 years old, who's having a big stroke, is not an uncommon, you know, kind of patient that we see. So I'll just play.
Valerie,
Can you hear?
I want you to tell me, what is your name?
You'll hear, that's Dr. Devlin's voice. You probably heard that on the phone at night.
She's a basic. Valerie, close your eyes. Close your eyes. Open your eyes. She's able to follow commands. Big smile. Show me your teeth. Big smile. Show me your teeth. She's very weak. Big smile. Show me your teeth like this. Good. She's very weak on the right face. Let's take a look at your arms, Valerie. Raise this arm up. Good. Raise this arm up here. She has a left gaze preference, and she's very weak. She's essentially paralyzed in that right arm. Okay. Can you raise this leg here for me? Raise this leg. Good. Raise this leg for me here. Okay. She's paralyzed in the right leg. Good stuff.
So obviously, in a young patient like that, if she was left with that disability, you know, paralyzed on one side of her body, unable to speak, I mean, huge impact, obviously, for her life and for her long-term, you know, prognosis. Unfortunately, a lot of these young people are the ones, as you know, that don't survive their strokes. They get, you know, edema, swelling. Their brain doesn't tolerate a lot of that. So, you know, this stroke, a very high death rate. You're looking at, you know, kind of at least 35%, 40%, you know, death rate from that type of stroke. So 26, obviously, it's, you know, that's a huge tragedy. So this was kind of early days when we first, you know, had a Mercy retriever to kind of work with, to go up there and try to pull the clot out. So I kind of say there's, you know, we'll get into devices, but there's kind of clot pluckers and clot suckers. So this was the very first clot plucker, you know, kind of go up there, you know, tangle it in the clot, and I won't move too far, John, I'll keep on. But you can see that this is a picture, you know, blood vessel, internal carotid artery coming up. It's like we're looking at the patient, and so this is right behind her left eye. And so the you sort of see on the after, it should look like there's kind of football goalposts, you know, a vessel going off to one side and one to the other. Here's the cutoff, so this clot is basically, you know, blocking all of that blood supply. We were able to get it, you know, back open. And so when you restore the blood supply, obviously that, you know, reverses a lot of this process that's happening from the stroke point of view. And so here she is 2 weeks after. A lot of patients, as you know, you guys, you know, see this every day, you know, they don't miraculously, you know, resolve their symptoms just like that. We do see that type of a scenario. I'll show you some of those kind of patients. But, you know, during the time that the blood supply was blocked, obviously these brain cells were, you know, significantly stunned or in the process of dying. And so it takes often a while for you to, you know, even if you are going to go on to make a great recovery, for that to kind of happen. So here she is in her rehab.
Valerie, tell me, how are you doing?
I'm good.
Great. Big smile. Show me your teeth. A little bit of that looks great. Hey, can you raise those arms up? Raise those arms up for me. Fantastic. Let me see you walk over there towards the wall and back. Good. And come on back here. Super. Hey, you just look great. Well, look, you keep doing your therapy. I'm glad that you're doing so great.
Thanks.
So, you know, that it's very rewarding, obviously, as you guys know, to, you know, deal with these stroke patients that have a great outcome. You know, obviously, because we're dealing with these large vessel strokes, they don't all have this outcome. You know, there still is a number that will go on to die, a number that will go on to have permanent disability, but certainly no treatment versus treatment. A lot more people with treatment will get better than if you do not treat. Any questions, you know, at that point, or you guys, you know? So here's, you know, kind of I put this slide in. These are all different faces of people that have had strokes. So again, it's not, you know, kind of all the 75-year-olds that have atrial fibrillation. We get a mix of all kinds of patients, even young patients. It's a 13-year-old that we did that procedure on, who was visiting our area. She did have a history of Down syndrome and some congenital heart that had been corrected when she was younger through a clot. This is her at discharge just a couple days later, completely neurologically intact. So, you know, so it's, again, you know, this whole number of patients that we're having from a stroke point of view, all these young patients, several years ago, Tom and I sort of, you know, said, hey, let's kind of organize this a little bit because, you know, we were seeing a huge volume of people. Let's develop Stroke Center, which has many moving parts. As you know, it goes right from EMS to, you know, all the way through to your guys' care, the aftercare with rehab. So all that is part of the team. You guys are essential in you know, the work that we're doing. It's not, you know, there's a fast timeline, obviously, to get this person treated, but then the aftercare is probably as important or more important in a lot of ways. So, so from the, you know, the Stroke Center look, you know, where this hospital has kind of, you know, got all the players involved, the interventional neurology, you know, like I said, you guys, the hospital administration, who kind of gives us the platform to actually, you know, practice here, and the equipment. So it is a team approach, and you all know Dr. Devlin, you know, so he certainly is a champion in his team of recognizing, you know, who are the candidates, so to speak. So going down, seeing that stroke patient in the ER, hey, this is a person that would benefit from our therapy, and so we, you know, we get mobilized and come in and treat the patient. It kind of breaks down that there's all this network of hospitals that are feeding into Erlanger. Right now it's probably at about 75 hospitals that will ship stroke patients to us. You know, Erlanger obviously is the hospital where this is all happening, and then there's kind of an arm. We're involved in a ton of the current research trials, you know, so basically all of the, you know, ongoing interventional trials we have a part in as well. And so that becomes important too in your care. Sometimes this patient is, you know, a study patient versus someone that isn't in a study, and there's certain things that we need, you know, for study patients versus, you know, if they're not in a study. So sometimes that's why there might be a little different, you know, in their aftercare, and you're saying, well, okay, why did they want this in this patient and they didn't want it, you know, in this patient? It's because they're, you know, actively involved in a trial. You know, we all know where we live geographically, but we, you know, this is kind of showing this catchment area that we, you know, get these patients from several states, you know, Alabama, North Carolina, down into Georgia. So it's a fairly big catchment area that we have. You know, obviously here's Erlanger. And kind of the way it lays out at Erlanger is, you know, you sort of all know Life Force. It's kind of dated now. I think it's 4 helicopters, and so, you know, this is the obvious, you know, place for the, you know, people in this area to come because of the ER. We're kind of using the trauma footprint where you can get people in here quickly with Life Force. You know, now that there's a interventional treatment for stroke, you've got a timeline. You want to get that patient in and get them treated, just like a, you know, a STEMI and those kind of, you know. So we want to get a fast door to intervention, you know, time period. This is, you know, showing basically that we do a lot, or, you know, starting to do more of that telestroke networking. So, you know, these people that come into these ERs and other places in our region, they can, you know, kind of ship in the patient data. They can examine the patient via the robotic stuff, you know, sort of see if they are a candidate. Yes, go ahead, you know, send them, and they'll put them on, you know, send out either Life Force or an ambulance to go and get them. The stroke volume has really grown over the years. You can see in 2012, you know, we're 1850, 2013 kind of closed out, and I think we were around 1900, so it's, or north of 1900, so it's, that's what makes us, you know, that number makes us one of, if not the busiest in the country from that kind of volume. So we had a chance to have President Bush here a few years ago. He didn't look very impressed with the stroke stuff, but he was. We had fun at Porker's restaurant, so that was a big. That was the big joke. We came for a stroke visit, and it was okay. We went to Porker's restaurant for for it's like, okay, this is not the stuff that's causing all the strokes, but yeah. So we've had some good experiences, and the center here has had a lot of, you know, kind of not only local recognition, but obviously national and international recognition. And I'll go through some, you know, cases. You know, this was actually the first case because this is sort of our heritage from an interventional point of view when we're using devices. This was a retired physician from the hospital, so he retired, went on a nice trip, came home. This was right at New Year's. Wife went out to do some errands, came back, found him kind of collapsed on the floor. So he was about 5 hours, 15 minutes, you know, into a big stroke from when she, you know, we got to him. So at that point in time, 6 hours was our cutoff to go in with a little microcatheter and drip in some of the TPA. So we did have this new device, a little corkscrew Mercy retriever you probably heard about. So that was, you know, kind of the first generation that we had to go up there and actually try to pull the clot out. So with him being at 5 hours and 15 minutes, I didn't want to mess with this kind of newfangled device to say, okay, you know, and run him out of his TPA time window. So I thought I'll just drip in some TPA, you know, the usual kind of treatment to try to get the clot dissolving, and then work with this little device. So you'll see that's a catheter. We're putting some TPA in, and then this is the tip of the catheter now downstream from the clot. So the clot kind of ends here. And this is, you know, the usual scenario. The clot is kind of plugging the vessel. The vessel's normal. It's not like it's disease, as opposed to the heart, where, you know, most of the time when you know, someone's having a heart attack, the vessel is diseased. There's a lot of atherosclerotic plaque narrowing it, and then it's also blocked. In our case, it's just more of this clot has come from the heart, you know, shot off north, and is just, you know, plugging the vessel. So, you know, everything downstream is wide open, so if we can just get that clot out, then, you know, the blood supply will be restored. We don't often have to leave a bunch of stents or that type of thing in there at the brain level. So I'll show you some cases where we have to at the neck level, but often at the brain level, we don't have to mess with any of that. So then, you know, I also kind of say this is our first case. We didn't know how to spell Mercy. It doesn't really have an E on it, but we were early in the game. So this is what you know, kind of the corkscrew looks like, and you know, and it's embedded in the clot. You can see that it's kind of deformed. So we can't see the clot, but you can kind of get an idea that you're in it by the fact that it's, you know, kind of changing the shape of the device. So we just did one pull, and this is what, you know, kind of the blood vessel should look like, sort of all of the branches filling. So we got the clot completely out, and here's what was on the little corkscrew. So it was kind of a piece of gristle, and so that's kind of the stuff that would, you know, form in your heart. And Amy slash Vanna is holding up the Mercy retriever, so you can pass that around and take a look. It's a little like spring. And then this is the stuff, good breakfast, kind of slides. This is the stuff that was, also in the backwash of the our catheter. So all of this clot would have, come from his heart and shot off and was plugging the vessel. So this slide is important in the fact that, our choices for treating these stroke patients is, IV TPA is the only FDA-approved treatment, for dissolving clot. But you can tell in these large vessel occlusions, that's our target. These people that have the big vessels plugged up with clot. If you see this amount of clot, that's why IV TPA doesn't work in all patients, because you can imagine trying to dissolve all of that clot and the time it would take, if you just were doing it with giving someone medicine, intravenously. So that, now that's what we're really working on is like, who best gets treated with intervention. Go in there, you've got a large amount of clot, go pull it out or suck it out, versus who is best treated with, kind of just the IV TPA. We still give all of our interventional patients here, if they come in within the treatable window for IV TPA, so now it's extended to 4.5 hours versus, it used to be just 3. We still give all those people, IV TPA and then take them on to angio. So the worst case scenario, we shoot their angio and it's a normal angio, the clot's dissolved. But like I said, in most of our patients, because we know from the imaging we do beforehand, from the CTA and stuff like that, we know they've got a big chunk of clot. So when we take them to angio, we see, hey, they've still got a huge amount of clot there, and we go ahead and pull the clot out. And then if they are after that 4.5 hour window, those people wouldn't have had any, they're not candidates for IV TPA. So we extend the treatment window for intervention. It's up to 8 hours, and then we can treat people even later than that. So the people that are wake-up strokes, or people that have good imaging. And when we mean good imaging, we always do a non-con, head CT, just rule out hemorrhage. But then we do a CTA to look at the vessels. That helps us tell which ones are plugged. And then we also do a perfusion kind of study of the brain. And that's really telling us, trying to get at how much brain, when this person comes into the ER, is dead. We're not going to recover that brain, versus how much is in jeopardy of dying and is kind of still salvageable. So if someone has, you can't really base this just on time. There's people that we see, if they plug up their vessel, the number is about, 2 million neurons are dying every minute that your vessel is plugged. But, some people run out of their ability to be a good candidate. In other words, they plug the vessel, 1 hour later, they'd still be within a treatable window. But because they don't have good collateral vessels that they can kind of do a bypass and tread water during that time, they basically, all their brain is dead, and no matter what we do, if we give them IV TPA, we open up the vessel, it's not going to make the brain any better. The brain is already, dead. And those are the ones that if we treat, they often go on and have a big hemorrhage, and it's just, it doesn't help. The ones that we do help are ones that have a small amount of dead brain, but a large amount of brain that if we left the vessel plugged would go on and die. So we're looking for people that have salvageable brain. Does that make sense? So that's kind of our selection criteria. This was actually, I don't think this video plays on my. I'll have to get John to help me out. I remember when I transferred these over, this gentleman's video. Anyway, this shows the person that we treated there and pulled all that clot out on his 30-day follow-up, and he's essentially normal. So I'll show you sort of the devices. Amy's passing around our little Mercy retriever. We also have now we've kind of gone on from that corkscrew design to more of these stent designs. So we just basically have the stent. It's collapsed, kind of compressed in a little microcatheter. We deliver that to the site of the clot, expose it, and it's made of nitinol, so it springs open, and we'll get entangled in the clot, like you see, to your right, and then we pull it out. We let it sit in there for a few minutes to sort of get it nice and tangled in there, and then pull the clot out and pull the stent out. So it's a stent that you don't leave in the vessel. You're using it to just basically get a hold of the clot and pull the clot out. So those are our newer, what we call stent retrievers. And then so those are the clot pluckers, and this is on the clot sucker side. You've got these aspiration catheters that range in size depending on the vessel that we're working in, that we go up, and this is like a little plunger. So we basically bury this in the clot. The catheter becomes occluded with clot, and then we take that little, sort of what we call a separator and try to plunge out the clot. Very sophisticated. I mean, we could learn a lot from plumbing. I'm going to go and sort of say, okay, what are some of your tricks here for these really difficult clots? Yeah, this is it right here. So this is the vacuum cleaner or the roto-rooter. So this is the penumbra catheter. So if you see these kind of things, so penumbra makes more of the the aspiration or clot sucking catheters, and then now the stent retrievers are Solitaire and Trevo are the two that you may see names of, or they're in these trials. So Solitaire lines up with a Swift Prime trial. There's a Trevo registry. There's, so all these companies are keeping track of how this is doing for patient care, and then they're going to use that obviously to go to the FDA and say, hey, for this subset of patients, people with a large amount of clot, having a big stroke, this is the treatment of choice over just giving them IV TPA. So that's kind of where we are. So we kind of talked about this, who we treat. It's people that have the big vessels plugged. This, is showing your vertebral artery coming up to the basilar artery in the back part of the brain. So that stroke is a bad stroke. I mean, if you plug your basilar artery with clot, it's a 95% kind of death rate if you let it go on to be blocked. And then in the internal carotid, it's the distal part of the internal carotid and the M1, segment of the middle cerebral artery that are kind of the target vessels. And that's, for whatever reason, these are the areas where a big hunk of clot likes to go and get hung up when it, shoots off and, from your heart. So we talked about death rates. I mean, if you look at any of these, they're bad. So basilar artery, we said north of 90% death rate, MCA 30 to 35. If you plug that distal part of your carotid at the brain level, it's about a 50% death rate. So these are kind of the big bad strokes. We deal with a lot of different anatomies. So this is just sort of showing you, when we come in, we have to build a platform. So it's always from a femoral approach. So all your patients will come back. Usually we always try for a closure device because they've often had maybe IV TPA and all that kind of stuff. So we'll go femoral approach. Deal with, kind of, this is a fairly straight, forward arch with, here's the, innominate artery coming to the right side, left common carotid artery, subclavian artery to your vertebral artery. So we look at the anatomy. Sometimes it's in these older patients, it's very tortuous, so a big dive back here and bad angles. So it can take longer sometimes for us to do a procedure based on the access. Access can be a little bit of a challenge sometimes. We have different, shapes on our catheters and stuff to try to deal with, different curves and bends and twists. So we have, we pick one of these catheters to then deliver a balloon guide catheter, and we're going to use a stent retriever. So the balloon guide catheter sits in your internal carotid artery, and we can flow up the balloon when we're going to pull out the clot. So we sort of want to stop the flow, so we're not, pulling against flow or have flow wash any clot where we don't want it to go. So we blow up the balloon, the stent retriever, here is showing it that's being pulled down with the clot in it, and it's being delivered through that little microcatheter. So we're just gonna. Here's a video of kind of what we're doing. So you see, this is a side shot of the net. So this is kind of real time of putting these catheters. So this is the guide catheter going up into your internal carotid artery, and then this is the microcatheter and the wire going up brain level. So that's kind of, we're looking on fluoro, navigating that. So from the groin level, those catheters are coming out. They're all in the 90 cm, 100 cm, range of length. And we're kind of playing a video game here to get the stuff where we need it to go.
Sir, how old are you now?
Coming in with a big stroke as
Okay,
well.
open your eyes wide. How many fingers do you see?
2.
How many fingers do you see here now?
Put this arm down.
None.
How many fingers now?
None.
Big smile, show me your teeth.
Big smile.
So
big
he's
smile.
awake, he's alert, he has a dense left field defect, he has marked weakness on that left face. Raise your right arm for me, sir. Let's see what you can do with that left arm. Can you raise that left arm? I'm going to stimulate you a little bit here on that left arm. Okay, so with deep stimulation, just a touch of cerebral posturing, that's all. Can you raise that left leg? Raise your left leg. Okay, so he has some strength in that left leg as well. Okay, sir, we're going to try to get you fixed here, okay?
So this is, again, sort of video representation. His right carotid has some contrast in it, and is completely blocked at the brain level. So this is one of these 50% death rate kind of strokes. This is our guide catheter that you saw the little tip of it getting in place. So here we are with a catheter that we're going up at brain level. This is a kind of a magnified view. There's his orbit. So we've got a microcatheter and a wire sitting in the vessel that's blocked at the brain level and bringing up another catheter that we're going to kind of use to deliver the little corkscrew through. So we're going to take a picture so you can kind of see the clot is blocking that vessel down around this bend where these catheters are. So it's sort of sitting right at where those football goal posts would be. So it's kind of right at the top of the post. And that shows you a better picture. So where the gap is where basically the vessel's been blocked with clot. So once again, the vessel, beyond the clot, totally normal. So we can just get the clot out of there. The vessel should be returned to normal. So here's kind of, again, a video, showing you what it looks like when we're doing that and looking on the fluoro screen of putting that, this was a retriever, entangling that in the clot. And then kind of pulling back, so it's like a little spring, and you want to try to keep it, so it's in that spring shape. It will stretch and pull. And you can try this on your friends at home and see how if they're practice it and see how it looks. So yeah, so here's kind of pulling it back. In this case, there really isn't much stretching of it. Sometimes it would stretch almost to a straight string and pull through the clot. So just depending on the clot composition, some of these clots are like a little pebble that's been sitting there for a while. Some of them are very soft and not that firm, if you like. And this is down to where the balloon is inflated, the tip of our balloon guide catheter. So we're hopefully sucking and pulling the clot into the tip of the big guide catheter. So we take a picture and voila, so this was all blocked before. So now that's what it should look like. So the blood supply is back to normal. Just kind of a few little nuggets of clot that we got out on the actual retriever. And then here's this gentleman just
okay, sir, close
less
your
than
eyes
24
tight.
hours
Open
after.
your eyes wide. Look over here. Look over here to the right. Good. His eye deviation is fine. Smile for me if you can. Smile. Symmetric smile. Eye deviation looks good. This is less than 24 hours. Right, show me 2 fingers over here. Good. Let's see that left arm. Raise that left arm up. Look at that. Show me 2 fingers right over there. Excellent. Raise it right up in the air.
So that was the side
Get it
that
right
was
up.
paralyzed
Excellent. Excellent. Very good. Can you raise that left leg for me? Fantastic. Fantastic. Give me a good squeeze over here with that left. Boy, I almost break my fingers over there. I almost break my fingers. That's fantastic. Good. You're doing great.
Get that tube out. That's right. So I put this in because that is one difference for if you've have been around here for a while. When we were doing all these cases before, we did them all under general anesthesia, and now you'll see a lot more patients, or all the patients come up and they just receive moderate sedation. So one thing we learned from our early experience, it was obviously important to do the procedure, and if you were tugging on that clot. There's some stimulation of the patient. They feel like some traction of those vessels. So often when you were trying to pull the clot out, there'd be moving and, that kind of thing when you didn't want them to move. So we do it all under general. But in looking at how people did after, the general anesthesia was actually kind of negatively impacting, how the patient did. So, basically we've, changed strategies. The newer stent retrievers are less stimulating than the Mercy retrievers, so they don't, get as much patient movement. And when we use the little clot, the Roto-Rooter clot, sucker, again, not as much stimulation, so we can kind of easily get the procedure done with moderate sedation. Sometimes, we'll have to go to a general if the patient isn't protecting their airway well or that kind of stuff, or they have a posterior circulation stroke where they're, basically comatose when they come in. But if we can, we like not to intubate them because, as you guys know, with intubation, they get a lot of other comorbid stuff. They get pneumonias and yada yadas, and so it's just, that's something you'll see from nursing care that more of these people, won't come up from our procedure still intubated. And here he is just a few days after getting ready to get out of the hospital.
How old are you now, sir?
I'm 57.
57. And man, tell me, what did he look like when he first came in?
I did not think he was going to make it.
You didn't think he was going to make it?
No, he could not move at all.
Couldn't move on that side at all?
No.
How's he doing now?
He's fantastic.
He's fantastic. How are you feeling now, sir?
A number one.
A number one. Raise your big smile for me. Good. Raise those arms up in the air. Fantastic.
Yeah.
Can you really walk down the hall?
I done walked down the hall 3 times a day.
Let's see you
I walked up the steps.
You walked up the steps.
Uh-huh.
You're there working on your phone. Come on back here, sir. We're not going to let you escape here quite yet. Do you feel pretty normal?
Yes, sir.
What do you like to do when you go home?
I'm going to go play with my cows. I got one about ready to calve.
You going to go play with your cows because you got one ready to calf? You better go deliver a calf, it sounds like.
Maybe.
All right, well, we're glad that you're doing so well, okay?
Well, me too.
That's fantastic. Okay, sir, that's great.
View here. This is that lady that we just saw a brief glimpse of. Same thing, that's her where she's, sort of paralyzed on one side. This is a clot that we pulled out of her vessel using that clot sucker, so you can see that there's a huge amount of clot. But when we don't intubate the patient, what we're also seeing is that, when we get that blood supply back, often these people right on our table are, resolving their symptoms, and you can actually watch them kind of wake up. So she was, fairly, paralyzed one side, unable to speak. Okay, here we are 5 minutes post-procedure. Ma'am, tell me your name.
Rhonda Shirley,
Okay, and do you know where you are?
Erlanger.
Okay, take a look over here for me now, okay? And then look way over here, okay? All right, now I want you to raise that left arm for me, okay? Okay, can you raise it up? That's great, okay? Can you put it way up there? So yeah, so she was paralyzed. Great, okay. Left, and this is how about your left leg now? Can you move that? Wow, that's just incredible. Yeah. That's great. So there's lots of benefits to not intubate the patient. So that's one of the things we're doing. I'll just mention this kind of briefly because sometimes you'll see, again, from nursing care, most patients that we deal with, we don't put them on any antiplatelet therapy and all that kind of stuff. We're trying to minimize, the amount of, if you like, blood thinning medications we're going to give them because, we know there's an area of brain. Usually in these people, they do have some dead brain, damaged brain. Hopefully it's a small stroke, and that normally, will undergo some little hemorrhage within it. So we don't want that small amount of hemorrhage to become a big hemorrhage that will, set the patient back. So, especially for that, first 24 hours where we've turned the hose back on, kind of full blast, so their vessel was blocked, and then when we, open the vessel, or reperfuse that area, we don't want them to get blow something and have a big bleed. So the only time we sort of, do the antiplatelet routine is if we put a stent in, a carotid artery, then we have to basically put them on antiplatelet to try to keep the stent open. So I show that, we have quite a few people, about a third of our patients will have, both a carotid, stenosis, a tight pinch like that, or the vessel's blocked, and they've also shot off part of that clot, and it's in their brain vessel. So we kind of have two things to deal with. We've got to go clean out the brain vessel that's plugged and get this carotid back open. So when those patients come up, you'll see that they, if we put a stent in, they will be on the, the antiplatelet, the Plavix and the aspirin and that kind of routine. So that's a little bit, again, just different in their post-care, and why we do that is if we've only, if we've had to use a stent. I'm going to just skip through this for kind of time. Let me do this. Yeah, you guys have all seen, well, here we go. I'll just do it. I'll just flash through the pictures. So again, person coming in with a stroke, this is their pre-imaging that we do, the CTs. So this is showing a side shot at the carotid level in the neck, and we've had to use a balloon to open up. The carotid is just a stump here, so it's completely occluded, and there's clot in the brain, so we can go through that, little occlusion in the neck, take our microcatheter up so we can still go through the block side, if you like. Here's the clot that we pull out on a stent retriever, and that's the total amount of clot that we got out. And then the vessel is completely open now, and then the neck vessel is open as well. So this was blocked from here, all the way up to the brain level. So often we have to reconstruct, and that can be why it maybe takes longer sometimes too in a procedure, is we have to, deal with getting the carotid vessel open.
Okay, sir, thanks.
So I'll sort of switch gears, and then we'll kind of leave some time for questions. So that's all the stroke side, being ischemic stroke, clot plugging vessels, carotid that is shut down, from a stenosis and throwing off clot. On the hemorrhage side, obviously we do a large number of procedures too, with aneurysms and AVMs and fistulas. You see those patients that come up, and so I thought I'd just kind of talk a little bit about coils. So when you get a coiling patient, you kind of know what we've done. So obviously 2 ways to clip an aneurysm. If you take this bubble being the aneurysm, neurosurgery, they'll go in and they have to expose the vessel. They're coming from the outside. And they'll put a little, kind of clip across the neck, or you can treat them from an internal approach. We're using, the blood vessels like a highway to get to the aneurysm. So we come from the inside and put a little microcatheter in the aneurysm, and then pack the aneurysm completely full of these coils. And how the coils are a treatment, basically when you pack them this full, the blood won't flow in the aneurysm anymore, and it's the blood that's kind of flowing in there that's making the aneurysm pulsate and stretch and potentially break and bleed or get bigger. When we pack it full, there's no, the blood doesn't go in there anymore. The aneurysm will just heal over, and it's okay for the patient to have this tight little ball of coils, sitting there for life, because basically the aneurysm's in a fluid-filled space, the subarachnoid space around your brain. So that's what coiling does. We'll cut off the blood supply by packing the aneurysm. So here's a picture. So this is a basilar tip aneurysm. So it's kind of like the vessel comes up, and it shouldn't have a head on the snowman. So it sort of looks like there's the round ball is the aneurysm, and this is a video of kind of treating it. So we've got a real loop-de-loo in the vertebral artery in the neck, so we kind of have some soft catheters that can do a complete loop, and we're navigating up our guide wire and the little microcatheter. You'll see we'll put the microcatheter in the aneurysm here. So there's the microcatheter in the aneurysm. And then you'll see here's a coil going in the aneurysm. We have all different sizes, so if we measure this aneurysm and say it's a 7-millimeter aneurysm, we've got a 7-millimeter coil that's a certain length, and we can just, unravel that. It'll take the shape, so the metal that the coils are made of has a memory, and it'll go to that shape. These coils and the metal have been picked, to be okay, so you can have MRIs after you've had your treatment, and they're not going to cause the patient any problem from compatibility. So we go ahead and put a complete ball of coils like that. And when we take our final picture, you can see that there's no blood going into the aneurysm. It's all just flowing in the vessels around it. And so that will go on to kind of heal, and the patient will be, kind of done from that point of view. So often our elective coil cases come in, day of the procedure. We keep them one night in the ICU, and then we'll say, okay, they're doing great. They're just recovering from their femoral, kind of puncture and the anesthesia, and then we, see that they're doing okay, and we often discharge them right from the unit, which is kind of, a little unusual when you, go home from the ICU.
Dr. Baxter,
Yeah.
how do you know how tight to pack
So
without rupturing everything?
Yeah, so that's a good question. I mean, but we know that aneurysms are thin-walled, and even to discover the aneurysm, about 60% of the ones we coil would be ruptured. So they've got a very weak spot. They've come in with their subarachnoid, but the coils are designed to be very soft. So even in all those scenarios, the rupture rate from a coil is like less than 1%. So they'll be very well tolerated. So we can usually fold them in there without them breaking the aneurysm, and then we pack we have a calculation of the packing density. So we measure the volume of the aneurysm, and then we try to achieve a certain packing density, because we know above a packing density of 25, 30%, they're likely to go on to heal the aneurysm. If we pack less than that, then it's, the aneurysm may still not be completely treated. So we kind of aim for a number in our packing density.
Because I noticed a lot of your packing percentages were like 43%,
Yeah.
27%. So
Right.
I was just wondering how you all knew.
Yeah, so we have so there's a nice little app that does the whole, says stop. That's right. So all the technology, but we used to just kind of do more an eyeball. You're packing fairly full, but now it's more sophisticated with looking at the actual packing density, and you can measure that. So yeah, the wonders of smartphone technology I just need it that it can actually do the procedure. Just be like, okay, Siri, coil the aneurysm. Yes, that's what we. Yeah, that's right. But good questions. So I think I just kind of gave you a little overview, but I'll leave some time just to see if you guys have questions about the the patients that you see coming up or any of that kind of thing. So, and Amy, I'll let Amy make a comment. What did I forget that would be important from the nursing care?
One of the things that I always have questions on when I go to the units is about our closure devices in the groin. Do you want to explain what an Aneurysm is?
Yeah.
Today, correct?
So you can see, depending on the procedure, we sometimes have to have a bigger hole where we make the puncture. So in the stroke world, that's our biggest sheath that we put in, which is a 9 French. That's a pretty good size hole, and especially if you're on IV TPA or you're on any kind of patients coming in or been on cumulatives or that kind of stuff. So we don't hold pressure anymore. So in the enclosure world, all these devices are you basically have access to the vessel. There's a little footprint that you put inside the lumen of the vessel, kind of snug that up to where the hole would be, the arteriotomy site in the vessel. And then the device that we use, all the material is actually pressed against the outside of the vessel wall right inside the hole. So it's an angioseal. So there's a little bit of dissolvable kind of packing material that we just tap down right on the arteriotomy site, and that obviously is providing a little patch where they won't bleed through that and allow the vessel to kind of heal. So that's an external kind of closure. There's different, so we're dealing with, we used to use per-close and pre-close and all these different ones, but we tend to use angioseal. So from we obviously patients not on any anticoagulation and stuff like that. Technically, they could get up and walk off the table, and this thing is supposed to hold nice and tight. But we don't advocate that. A lot of these people have some blood thinning, especially the coil patients. We intentionally give them heparin and stuff like that, so we can prevent any clot from forming on our catheters or coils. And so they will get kind of a bruise. We still want them to be treated like kind of normal. Don't move your leg, and if they have some bleeding and stuff like that, we may have to put some additional help, some sandbags or that kind of stuff, or some pressure to anything you look for?
Same thing that you're going to see if you get a patient from the ER who's come in emergently and they've got a fem site A-line and you're going to remove that. Same thing. You see bleeding from that site, hold pressure, call Interventional Radiology. We'll come up and look at it. Bruising, if it gets hard around the area within the first 24 hours after they've come up to you, same thing you're going to look for in any type of arterial site. But remember, if it starts bleeding, hold pressure. You're not going to hurt them because they've got that angiosyl in there. Hold pressure, definitely.
Yeah, and you can, so you can, that's a great point, you can, control really big time arterial bleeding by just pressure. So the thing that people often do is put some pressure on, take it off, but, just put the clamp down and hold pressure. With someone fully anticoagulated with a big, puncture site, you hold pressure long enough that vessel will actually heal over. So it's important not to kind of get intermittent pressure, but just hold pressure, you'll get control of that, the bleeding.
Do you know how long you hold it? If you've got active bleeding in the arterial site, how long do you hold direct pressure? 10 minutes.
Yeah, so that's what we would do after kind of a procedure. If we were not using a recording device, we just hold 10 minutes of pressure and then kind of let off and look and see if we achieve these things.
Yeah, do that 10 minutes minimum. Minimum.
Yeah, so that's a good point. Any other post-care, kind of stuff?
Do you have, depending on whether you do a culling or a clipping or a retrieval, like blood pressure parameters that the
that's a good
patients have to stay within?
That is a good question because for coiling, not so much. In other words, we don't push them wildly hypertensive, obviously, but usually these people come in, their blood pressure is where they've been living, for all the time leading up to their presentation or their electrification, and so we just try to keep them at their same, blood pressure. We treat obviously they're really hypertensive, but stroke patients, they all come in hypertensive. So when you plug that vessel, your body tries to do bypass. So it bumps up your blood pressure, driving as much blood to the brain, trying to encourage as much blood to go around that blockage. And so all those people, are way up there with their blood pressure. What we found is if we, kind of get excited with their number and say, they're way hypertensive. If when the vessel is still blocked, if we drop their blood pressure, then that's actually a bad thing. So then that was one of the things with anesthesia, their pressure was coming down to more normal range. But when the vessel is blocked, you actually want them to be trying to push as much blood as possible. But as soon as you get the vessel open, then you want the blood pressure to be normal because you don't want if you turn on the whole main pipe, you don't want it to spring a leak and break and bleed. So that's what we're doing after the stroke intervention cases. If we get, so it kind of goes down 1 or 2 paths. If we get the vessel open, then we want the blood pressure to be kind of aggressively treated to try to bring it back down to normal so we're preventing the risk of a hemorrhage. If the vessel stays shut, we want them to kind of be probably sort of hypertensive to, again, try to keep as much blood supply going around the clot as possible. So you can take 1 or 2 paths.
That'll be on your stroke orders also if we get a patient that we've done a mechanical thrombectomy on, we've pulled the clot out, that's on your stroke orders where you keep their pressure. Still, if we have pulled the clot out and you don't see a box that has been checked, you always want their MAP greater than 70. If we pull the clot out, you don't want to drop them too low because then you're going to get vasospasm, but you don't want them, their pressure through the breathing or because like I said, you're going to spring a leak and that's going to be detrimental to the patient.
So check, we sort of have been looking at where, we can flag that, make that easy to see that, okay, hey, this is a patient that we achieved recanalization, got the vessel open, treat the pressure, or keep the parameters here versus someone that the vessel didn't get open and you want the pressure to be a different thing. But it's certainly the stroke order set, sometimes, if it looks like someone hasn't checked the box and they should have, the things at 3 in the morning is, you can kind of get, okay, what you miss the check. But yeah, that's, so that's a good thing to know. So you can kind of ask, okay, where should we run the blood pressure?
And if neurologists on board, they will Interventional Radiology.
Yeah.
We're more than happy to help out. Okay?
So it's
That's pretty popular.
yeah, that's a good idea. Yeah, we'll even
Yeah,
do
his
some.
pager's the one on there, not mine.
We'll even do some other way. We'll still try to. Another question?
If they, just because they don't spring leak, if they've got a hematoma, they should mark it, correct?
Yeah.
So they can kind of keep up and if it starts getting bigger.
Absolutely.
That's
Absolutely.
So yeah, just mark a hematoma, it's expanding, you know, still. So it can be, you know, there's obviously, you know when it's bleeding, and you guys have all seen, but if it's just oozing too, that can be a problem. So, you know, just make sure it's not growing. All right, well, thank you. That was good.